wonderful introduction by Ollie. I really appreciate that. My talk today is very much along the lines of the academic presentations I've given at Grand Rounds at Walter Reed and at Naval Health Medical Center in San Diego very recently within the last year or so. So it's going to be very US centric, focused on our standards of care over here for PTSD. But I realize that, there's obviously a lot of differences, and treatment clearly needs to be tailored to the population, to the individuals who you're treating. And so, this is really just from the academic perspective of the US side, but there'll be not seeing them at the moment. Is everyone else seeing the slide? All right, no worries. Okay, great. Let's see it now. Okay, yeah. So, by the way, on this first slide, my email, it should read charles.w.hoge.civ@health.mil instead of mail.mil. They keep changing our official email addresses here. So it gets very confusing for all of us. Next slide, please. So my objectives today are just to describe our perspective of evidence-based treatments from this side in the US, and summarize challenges and barriers to treatment. I want to focus a lot on how I view trauma-focused treatment, which is looking at the core components of what we do when we provide therapy, rather than the individual treatment packages. I think people often get focused on whether a particular treatment package is evidence-based, when in fact that package has very similar core components to other types of treatment. And so I come about the topic of trauma-focused treatment from the standards of what are the similar inherent core components across lots of different treatments that we may be providing. I've used a lot of sources for this talk, mostly focused on randomized clinical trials and some other types of analyses that are in the literature. Next slide, please. So the care that we deliver in the Department of Defense and the Veterans Affairs here in the US is guided in part or maybe largely by our clinical practice guidelines. And we go through a guideline revision process about every 6 years. There are experts selected from both the VA and DoD for those guidelines. And the PTSD guideline was just updated a few months ago. So the previous guideline, I was part of the previous guideline in 2017. I wasn't part of this latest guideline. And I'm going to compare and contrast the two, because I think that in some respects, what happened with this latest guideline was going in the wrong direction. Rather than expanding treatment options were actually narrowed. And I think that that's a product of how the analysis was done. And I don't think that it's actually a very accurate way to look at the literature. So I'll kind of try to break that down a bit. Next slide, please. So this is a table which shows the comparison between the 2017 guideline and the one that just came out. And again, our clinical practice guidelines are really the foundation for health policies that are written to try to standardize care across the DoD and VA. They're written in a way to provide an evidence-based synthesis of the literature to help clinicians understand what therapies might be considered most evidence-based. And in 2017, we included language. We said the first line treatment approach for PTSD, which was a strong recommend, was trauma-focused therapy with components of exposure and cognitive restructuring. I'm sorry, that was misspelled. It should be cognitive restructuring instead of restricting. And there were 7 or so different types of therapy packages that we included that clearly met the criteria that we established for components of exposure and cognitive restructuring. And that's cognitive processing therapy, or CPT, prolonged exposure, or PE, eye movement desensitization and reprocessing, EMDR, NET, which is narrative exposure therapy, which is Nooner's work in Europe with refugee populations, written exposure therapy, WET, which is a very nice short exposure therapy based on writing, brief eclectic psychotherapy, BEP, and then there was acknowledgement of other types of cognitive behavioral therapies that are trauma focused, for example, Eller's cognitive therapy. And so you can see on there's a variety of packages that have been developed by both US and European clinicians and experts in the field. In 2003, the first line therapy was narrowed. The language was changed to remove the core components, and only 3 therapies were given a strong recommend category. 3 of the original 7, CPT, PE, and EMDR. For second line therapy, non-trauma, there were several non-trauma therapy packages acknowledged in 2017. And in 2023, one of the trauma-focused therapy, actually 2 of the trauma-focused therapy packages were downgraded to second-line therapy, and one of the non-trauma therapy packages was combined with that. So they sort of mixed trauma and non-trauma therapy packages in that second-line therapy, which I think is also problematic, that distinction between trauma and non-trauma-focused therapies got lost. For medication recommendations, there's general consensus in the literature and among experts that therapy has more enduring effects than medication, but medications clearly do have a role in treatment of PTSD. And the medications that have shown the strongest efficacy have been in the SSRI or SNRI categories. And there are some of those, the medications that are listed here, like sertraline, paroxetine, and so forth. And between 2017 and 2023, there wasn't a big change there, although one of the 4 medications that was listed previously was dropped. And then there were no other strong recommendations apart from what I've listed on the table there in either of the recommendations. Of note is there's a strong against the use of benzodiazepines and atypical antipsychotics and cannabis, and that's fairly consistent between the clinical practice guidelines. Next slide, please. So it may be a bit surprising. It was surprising to us, and we published our critique of the latest guideline that just came out this month in JAMA Psychiatry. And some of the things that we point out there, I think that there was some decisions made in how the evidence was analyzed, which the committee agreed on, but which I think are scientifically problematic. And part of that has to do with an over-reliance on systematic reviews and meta-analyses, which minimized the importance of strong individual clinical trials. And I'll show a few examples of that. I think that that there was another problem of not clearly distinguishing trauma and non-trauma focused therapy approaches. And I think that moves away from this idea of really understanding what are the inherent core components of what we're trying to deliver when we deliver therapy. And as part of that, I think in previous meta-analyses and systematic reviews, many similar therapies were acknowledged to be, comparable enough to each other that the evidence for one therapy would support the evidence for the other therapy. So, for instance, that when there was numerous trials involving prolonged exposure, there were also some good trials involving narrative exposure therapy. They have similar core components involving an oral narrative exposure process, and so usually NET would be considered an acceptable exposure therapy. And similarly, with the different types of cognitive therapy packages that are out there that are trauma focused, there's a lot of different packages, but they all have inherently similar core components. But in this particular guideline, the experts focused largely on only on specific trials of specific therapies and didn't take into consideration therapies that were comparable because of their similar components. And then the other factor I think that we often don't take into consideration enough is the importance of considering the impact of treatment dropouts and engagement in care. The single most important reason for failure of treatment is dropping out of care. And in the US, we have upwards, sometimes as high as 50% of individuals who start therapy not completing therapy. And that's really the biggest reason why efficacy is not optimal for the treatments that we provide. And so I think that the most fundamental thing that we can do in the care of patients with PTSD is to focus on how to better engage them in care and ensure that they stay in care and not worry as much about the specific therapeutic techniques that we may be providing, because it's the engagement piece which is going to have the most impact. And there's some very good evidence actually on the efficacy of non-trauma focused therapies being almost equivalent to trauma focused therapies, which supports that viewpoint. Next slide, please. So how do we best interpret the evidence and optimize treatment? I think the first priority, and this is again based on our experience over here, is to set the initial treatment goals around building the therapeutic alliance and strengthening engagement in care and really understanding what are the barriers that are going to prevent that individual patient from being able to come in for a sufficient number of sessions to get the care they need. I think another big thing that derails treatment is the coexisting conditions. And I rarely see an individual with PTSD who doesn't have significant comorbid problems like substance use disorders or sleep conditions or chronic pain or other chronic medical conditions or psychiatric conditions. And so those conditions often make it difficult to address the trauma-focused portion of what the treatment needs are. In terms of selecting a therapeutic approach, I think there is general consensus that therapy takes priority over medications. But I think it's important to distinguish between trauma and non-trauma focused options, understand the core components of trauma-focused therapy, and then apply those components in a flexible manner based on patient preferences, again, emphasizing engagement in care. And I think that from the standpoint of many of the experts in the field, for instance, at the National Center for PTSD, I think they would disagree with that bullet. They would say you want to utilize a evidence-based trauma-focused treatment and with strict adherence to that particular treatment manual. Whereas I think the literature broadly supports a more holistic approach to care. And this is something which we've debated a lot over the years. And then I think that we also have to have understanding of therapeutic processes that attends to the body and processing. The somatic component of PTSD is huge. The title of the book, Bessel van der Kolk's book, The Body Keeps a Score, really does say it all. That really is an accurate title, of a book to describe what people go through with regard to trauma. and really helping people to understand the biggest psychoeducational piece is helping people to understand their own physical reactions and physiological reactions when they get triggered to trauma triggers. And when they have that understanding, maybe those triggers still happen to just the same degree that they happened before, but at least the people have more understanding of what's going on with that. And then I've been thinking a lot about the role of different types of mechanisms of recovery. We focus a lot on the exposure or extinction learning mechanisms, but I think that there is a emerging evidence on the optimization of processes that might lead to improved reconsolidation of traumatic memories. And I think that's a very exciting field of pursuit going on right now. Next slide, please. So here are the core components of trauma-focused therapies from my perspective. I think that when we talk about therapy for PTSD, and I've listed some examples here, but I'm sure that if you're using other types of therapeutic processes for treating your patients, you can easily put them into these four core components. So the first component is exposure-based processes to the trauma narrative or the past events that occurred in the person's life. So that may be an oral narrative process where the person repetitively talks about the past event that happened in order for them to gain better acceptance and understanding of that and integration of those experiences. You can also provide that past narrative trauma exposure piece through a written exposure process, and that's hugely effective in the latest clinical trials that have come out. Or you can use visualization or other types of sensory focused therapeutic processes. Visualization is the most common, and EMDR and other types of derivatives of EMDR, like accelerated resolution therapy, ART, primarily leverage imaginal or visualized exposure to trauma. You basically have the person visualize, put themselves back there again in their mind, and then work on helping them to process that. The second exposure is exposure to triggers. That would be exposure to the current situations that trigger them or the future things they're afraid of, anything that's going on in their person's life right now that is maybe kindling past memories or maybe kindling current anxiety. And in that, the types of techniques we use are in vivo exposure, such as what's used in prolonged exposure. In cognitive processing type therapeutic packages, we may use the worksheets that help the person to understand and break down, what was the triggering event? How did I respond to that triggering event? How could I reanalyze that or relook at that and process that and approach that maybe in a different way? And that's really a form of exposure to the current triggers. And then you can also use visualization in EMDR. For instance, you can ask the person to visualize facing the thing that they're afraid of facing, observe their somatic response to that, and then process that somatic response, and then help them to practice facing that in their mind. It's kind of a performance psychology approach, and it's actually very effective in phobia treatment or PTSD treatment. The third component is cognitive restructuring or meaning making or integration, and it may be very directly through a cognitive restructuring process, such as a CBT or CPT approach, or it may be less direct, where the focus is more on the narrative process, and the cognitive shifts or the meaning making occurs more organically or naturally through that process. And then the fourth component we spend a lot of time with are all of the various tools that we may provide to help the person regulate their physiology. So all trauma-focused therapies have some element of this, even just asking people to fill out a SUD score helps them to bring awareness to what's going on internally, and that can help them to feel better. And so there's a lot of techniques that we can use that in the physiological affect regulation. So I encourage you to sort of look at what therapeutic packages you're using and see, well, what are the component, how do the components of what you're doing fit in with these components? Next slide. So just a very quick overview of some of the literature. And I think, again, one of the reasons why I focus so much on core components is because when you look at head-to-head clinical trials of trauma-focused therapies, they almost always show equivalent efficacy. You really don't see one distinguishing over another. There was a very large trial of PE and versus CPT recently involving, I think, over 1,000 participants and JAMA Open Network in 2022. They showed identical results. There have been many other head-to-head trials showing comparable efficacy. Written exposure therapy, there's actually been several trials now of written exposure therapy compared with cognitive processing therapy. And all of them have shown equivalent efficacy. And there's very good data actually to show that written exposure therapy has better retention rates, less dropout, and can be delivered in a faster, more efficient manner than traditional cognitive therapies. But the efficacy has been comparable. The biggest problem with all of these therapies is high dropout rates. And so in randomized clinical trials, you often get about 25 to 30% of individuals dropping out in the course of therapy. In routine clinical settings, it can be much higher than that. And then if you look at among all patients being treated across our VA and DoD systems, there's a lot of research that shows that only a small percentage of individuals receive an adequate number of sessions, which is defined as minimally adequate care, an adequate number of sessions to have the opportunity for effective treatment. So many don't even receive the optimal number of treatment sessions. Next slide, please. So this is just an example of one of those head-to-head trials. This is from quite a while ago. This is one of the first head-to-head trials, and you can see the lines are identical for CPT versus PE. Next slide, please. These are just sort of for your reference material. This is the large trial I talked about of prolonged exposure and cognitive processing that just came out last year. Again, showing totally comparable efficacy. Next slide, please. This is one of Denise Sloan and Brian Marks's fabulous studies. This was in JAMA Psychiatry, comparing written exposure therapy to cognitive processing therapy. And the efficacy rates were equivalent, but what was remarkable was that the written exposure therapy produced those results in only 5 treatment sessions versus 12 with CPT. And because it was so much shorter in its ability to deliver that efficacy, the dropout was much less. And this trial has now been replicated 2 more times in both veteran and active duty military populations by this research team. So these are fabulous data. And this is one of the examples of, it just baffles me that written exposure therapy was downgraded from a recommend to a suggest, from a strong recommendation to a weak recommendation, and a second line therapy option, despite the emergence of these new, very well done randomized trials since the last CPG was done. It doesn't make a lot of sense to me because I think this is clearly an example where individual randomized trials, the data from those individual trials were minimized when you look, when the focus was on systematic reviews. Next slide, please. This is one of their replication studies showing exactly the same thing as the slide I just showed. Next slide, please. And then I want to also mention that this idea of there's a strong support for among many PTSD experts that therapy must be delivered with strict adherence to, the manualized treatment. But when you look at evidence from other types of therapies that have nothing to do with trauma-focused therapy, and there have now been a number of very well done head-to-head trials, some of which have come out since the last CPG, directly comparing non-trauma focused therapies with trauma-focused therapies that have shown identical results or very similar results as the trauma-focused therapies. It helps us to understand that the most important component was not one of those four that I showed before, but the most important component is what we all know, which is the therapeutic alliance and therapeutic connection that we establish with patients. That is we call it the non-specific effects of therapy, but it's highly specific and highly important. It may be the most important component. And so engagement is number one. And then talking with the patient and finding out what is going to work best for them that's going to help them to stay engaged. And if they say, I can't do this exposure-based therapy. I don't want to talk about my experiences in the past at all, but I'm willing to continue to come into therapy. You could view that from the PTSD treatment standpoint as being, their avoidance is leading them to say that. But you could also look at it from the standpoint, well, they're willing to come in for care, and there's actually a lot of other good options that are out there to provide care that does not involve talking about the trauma or visualizing the traumatic material, and that can be just as effective. And so we have a lot of options that we can make available to patients. And trauma-focused therapy, I think, is very important, but it's important when the patient is ready for it, and it must be delivered in a way that helps them to feel as comfortable as possible to do that. Some of the examples of non-trauma focused therapy that have been, have produced remarkable results compared with trauma focused therapies include present-centered therapy. Present-centered therapy is simply a manualized, structured, supportive psychotherapy where clinicians are taught, and it's designed. It's really not used for the most part. It's really not used in our normal clinical settings. It's only been used, for the most part, it's only been used in research settings. And it was designed as a control condition to control for all those non-specific effects of therapy, to compare with PE or CPT, but it was found to have actually quite effective, be quite effective. And those techniques simply involve focusing on the present, current, life situation and life stressors, and helping people to talk through those a little bit without any cognitive restructuring, without any trauma focus, without delving into the person's past, and it can be quite effective. Interpersonal therapy has been compared with prolonged exposure in a civilian population, found to be quite effective. I think the limitation in military research has probably led to why that got downgraded. I think IPT may even be in an insufficient evidence category now, and I think that's a grave mistake. It is an effective therapy, and I think that a lot of good quality trials in civilian populations are perfectly applicable to military populations. Yes, there are population differences, but the efficacy tends to be similar across civilian and military populations, though dropout rates tend to be higher in the military. Dialectical behavioral therapy has been found to have good comparability to CPT in at least one good quality trial. I think that was in JAMA Psychiatry. There's a phenomenal paper on transcendental meditation versus prolonged exposure. So now you're really talking about the component of purely affect regulation. That component, it alone can be as effective as the total package. And I'll show you a little bit of that data. And then And then there's some older literature on stress inoculation training without focus on the trauma itself being as effective as prolonged exposure therapy. So those are just a few examples. I'm sure there are more examples in the literature. Next slide, please. And here are some of those graphs. So you can see in Paula Schnur's trial from 2007, that was comparing prolonged exposure with presence-centered therapy. And you can see that prolonged exposure had a little bit faster efficacy curve, but by the end of the trial at 6 months, there was no statistical difference between the two groups. And then there was another trial in 2018 and another trial, several other trials that have come out looking at PE versus cognitive processing therapy versus presence-centered therapy that have shown comparability. And those are some of the examples. Next slide, please. This is the study I mentioned on dialectical behavioral therapy versus CPT. Again, not a statistical difference here. This was in women survivors of childhood abuse, so it may be the population may not be as generalizable as we would like, but again, the data are quite, I think, quite strong. Next slide, please. And this is that trial of transcendental meditation. And transcendental meditation actually did a little better than prolonged exposure therapy. All of these, I think for the most part, all of these trials were powered for non-inferiority, which means that they were powered in a way that's a statistical way of making sure that these are actually comparable. So again, this was the transcendental meditation trial. Next slide, please. So just a brief comment so I'll switch gears a little bit from the trauma-focused therapy. I talked briefly about medications, and then I want to go back to a little bit of the mechanisms of therapeutic recovery. So in terms of medications, they certainly have a role in treatment. A lot of patients really are not ready they don't have the time or the resources to come in, for one reason or another on a regular basis for trauma-focused therapy. And medications can be used and they're effective and they can help to blunt the symptoms, help the person to manage the symptoms. So they clearly have a role. And I think in the situation with combat veterans, we use SSRIs and NRIs fairly liberally in our service members in the Army and other services in the U.S., particularly in the Army. I think the Army has a very strong open-mindedness to the use of medications that do not require monitoring. These are medications that don't require drug monitoring. They're very safe. They don't have untoward side effects like drowsiness and that type of thing that would make it difficult to use in a combat environment. And so many of our service members deploy to combat zones on serotonin reuptake inhibitors. I can say that early in the wars in Iraq and Afghanistan, there was a lot of stigma for the use of medications, but over the years, it became very commonplace and very accepted, and most military leaders don't think of this in any negative way the way it used to be. Now, we certainly haven't solved the problem of stigma. It's still a big problem, but it's a lot better than it used to be. So SSRIs, SNRIs have a strong role, and I think they can be used in the combat environment, and they do not in any way impair cognitive functioning. They do not cause drowsiness, and the side effects are very manageable and do not interfere with a person's functioning in that type of environment. Prazosin has been used a lot for PTSD-related nightmares. It's a blood pressure medicine that dampens the physiological response that a person has when they have trauma-related nightmares. There's been some mixed evidence on the effectiveness of prazosin when compared with placebo. And I think actually one of its mechanisms of action is the fact that it's presented with such enthusiasm as a non-psychiatric medication. And so there are strong placebo effects. But that said, it has a role. I think that in many countries, and also even in the US with a lot of the practitioners, a lot of practitioners view benzodiazepines as a reasonable medication to consider in anxiety disorders and anxiety symptoms associated with PTSD. But there's some pretty decent evidence that that just makes things a lot worse for patients with PTSD. And so one of the consistent things across the years in our clinical practice guidelines have been to recommend against the use of benzodiazepines. I would guess that there's probably a fair amount of benzodiazepines being used now in the operational environment, and in Ukraine, perhaps. I don't know the details of that, but I would recommend against that, and I would encourage more education about the potential problematic effects. It may help initially with anxiety, but then it makes it almost impossible to get off of them because the anxiety can go up, the sleep can get worse, and there can be addictive properties with those medications. There's a lot of other emerging treatments, pharmacological treatments or biological treatments that are coming out. Stellate ganglion block, SGB, transcranial magnetic stimulation, ketamine, psychedelics. And I think that the jury's still out on most of those. We really don't know. We really don't have adequate evidence. I think one of the areas that we're starting to see pretty strong evidence for efficacy in PTSD is with MDMA-assisted psychotherapy. But the amount of man hours that you need to treat a single patient is enormous, something around 80 to 100 hours to effectively treat somebody by two psychotherapy professionals. So it's not a treatment that is currently feasible on any large scale, and that's the main barrier to its use at the moment. So that's sort of my little snapshot of medication considerations. Next slide, please. Okay, and then I mentioned, so I've talked about core components of trauma-focused therapy, and I now want to move into just in terms of the processing itself. And I think that the attention to the body is not only important in the affect regulation piece, but attention to the body is hugely important in the processing piece when we're doing the exposure-based processing. So it's important in the component of exposure to the past, exposure to the present or future triggers, and it also really helps with integration of people's experiences and meaning making when people can understand their physiological reactions and not berate themselves so much when they have those reactions. So next slide, please. So I'm sure you all are very familiar with kind of the neurobiology of the limbic system, versus cortical processes. And there's a lot going on in the brain, and there's a lot of structures which are sort of more primitive in their responses, and others that are like our cerebral cortex, where we have rational thought, time, language, etc. The survival parts of the brain, the limbic parts of the brain, connect directly to the autonomic nervous system. And so what happens when someone is triggered is the autonomic nervous system is immediately and reflexively activated even before the cortical rational processes kick in. So the person, might respond, have a physiological response that they don't quite understand. And then their brain kicks in and goes, you're not in a threatening situation right at this moment. Why are you reacting that way? But there's a little bit of delay in that process. And the autonomic nervous system is really what we're talking about when we're talking about trying to attend to the body. Next slide, please. This is a graphic from a book that I found in Italy in 19 in the from 1850, and it shows um, you can see the spinal cord, going down kind of the back left side of the frame there, and then just in front of the spinal cord is a nice thick cord going to actually running right along the spinal cord, right on the side of the spinal cord is one set of nerves, which is the sympathetic chain. Okay. And then there's this thick cord that runs down the front, coming out from the brain stem and running down the front of the spinal cord behind the organs, the organs in the chest cavity there. And you can see a lot of little fibrils breaking off from that. That's the 10th cranial nerve. That's the parasympathetic chain. Okay, so you've got your sympathetic and parasympathetic chain. And you can see some ganglia on the sympathetic chain that's the target of stellate ganglion blockade. But more importantly, you see tiny little fibrils, nerve fibrils branching out from the sympathetic and parasympathetic chain and going into all of the organ systems of the body, going into the chest cavity. And if you go to the next slide, please, you'll see it carrying down into the abdomen. So there's the sympathetic and parasympathetic chain coming down. And that mass of plexus that you're seeing here, those are not blood vessels, those are nerve endings. That is essentially a graphic just depiction. If you were able to dissect all the autonomic nervous system, that's what you would see there. So those dense plexuses of nerves that you're seeing in this graphic, and that's all in the gut there underneath the diaphragm, is from the sympathetic and parasympathetic tracts. And so this is indeed your second brain, and this is why we feel so much in our body, and why somatic processing is so important. Next slide, please. So I think maybe in the question and answer session we could talk a little bit more about how we do somatic processing. But I just want to say that the somatic processing component, I think, is very important in both the traditional exposure therapies as well as therapies that might tap into modalities of recovery like memory reconsolidation. So I'll just very briefly just comment on, most of our trauma-focused therapies are based on either cognitive theory or extinction learning theory, exposure-based theories, where by repetitive exposure to the feared stimulus, the person learns that they can extinguish their response, and that extinction learning is the traditional way in which we view the mechanism of effectiveness of trauma therapies. There's been more attention now on memory consolidation as well, and that's the idea that if you activate a trauma memory, in fact that memory, when it's laid back down after it's been activated, for the most part, it looks and feels exactly the same to us. So it feels to us like it's etched on our hard drive of our brain. It's a memory that's fixed. It's fixed in time in our mind. It's fixed in terms of what happened. The details of what happened are indelible. They don't change. That's the way it feels to us. But in fact, what's happening neurologically, every time those memories get activated, they get laid back down with new protein synthesis and are in fact new memories, even though they look and feel the same. And so there's been a lot of effort now to intervene at the moment when the memory is activated. So you do some sort of exposure component, and then you pair that exposure component with some sort of novel stimulus, or use a medication to intervene and block the reconsolidation process, or change or alter that reconsolidation process. And so I've been very excited to learn about this and been sort of exploring these ideas a bit. From the psychotherapeutic perspective, the idea would be, and there's a lot of imagery scripting types of therapy approaches, especially in Europe now. I think less so in the U.S. But it's the idea that you activate the trauma memory, and then you change the narrative in some way, to visualize something that's different or something that you want to take out of that experience that's going to be positive for you, and or pair it with some sort of image or memory that you want instead. There's a lot of ways to do imagery rescripting. Imagery rescripting can be done for nightmares, for instance, with CBTI and cognitive behavioral therapy for insomnia. Imagery rescripting is an important component of that, but you can also do that for nightmarish traumatic events that the person has actually had in their life. You can also do imagery rescripting to visualize yourself being successful facing certain things that trigger you. So that's on a psychotherapeutic level I think is very exciting. On the pharmacological level, there's been a lot of efforts to either block or enhance the reconsolidation process. D-cycloserine studies have been done comparing exposure therapy with D-cycloserine. D-cycloserine is a TB, tuberculosis antibiotic, actually, that was found to have properties to enhance memory reconsolidation in the central nervous system. And it's had mixed results when it's been paired with exposure therapy. And I think the reason for that is because if you have a session where the person has an aha moment and they have a lot of insight and they feel a lot better at the end of the session than at the beginning of the session, then if they have D-cycloserine on board, that will enhance that reconsolidation, that positive reconsolidation. But unfortunately, if they have an exposure session that sort of goes south and they end up walking out the door feeling, worse than when they came into the session, if they have D-cycloserine on board, it will actually enhance the worst feelings for them. And I think that's why we've had mixed results with that. Propranolol is really interesting, and short-acting propranolol and long-acting propranolol have been tried in various randomized trials. And I think that there's something to be said for considering how to use particularly short-acting propranolol paired with certain types of exposure sessions. This is not at the point where we can recommend this on an ongoing basis. And I think that one of the mechanisms of MDMA psychedelic assisted therapy is also changing the consolidation of that memory significantly, having a much different experience with that memory than the person had before. So I think that's one of the mechanisms. There are many mechanisms of the psychedelic assisted therapies. Okay, next slide, please. So this is an example of rescripting. This was a meta-analysis that came out a few years ago, and looking at the world's literature on rescripting. And there's various rescripting techniques used in a lot of different therapies. So I encourage you to explore that further. Next slide, please. And this is an example of propranolol. In this case, this was a randomized clinical trial of treatment of spider phobia. Okay, quite different than PTSD, much less complex, okay? But there are some parallels here that are potentially useful to think about. And particularly, for instance, in trigger treatment, or approach to, a lot of times people respond to trauma triggers very much like they respond to phobias. So in this case, it was a randomized clinical trial of individuals with spider phobia. And there's something called a tarantula approach task where, tarantulas are harmless for the most part, and they can be petted and you can touch them and so forth. They're not a danger to humans. And so there's a very standardized task called the tarantula approach task, where Obviously, if somebody has a phobia, they're going to be down at the one end of that spectrum. Maybe they can get as much as close as sitting in front of the spider, but they're not going to get near the jar or open the jar or pick up the open jar or direct this or touch the spider with a tip of a pencil that they're holding, or anything else, such as letting the spider walk on their hands. And so, um, this is a standardized task, and they randomize people into an exposure to the tarantula, followed immediately by short-acting propranolol, or exposure followed immediately by placebo, or propranolol alone without the exposure component. And they found that exposure plus propranolol significantly cured tarantula phobia or spider phobia in a large percentage of the people. So it was a pretty impressive trial, and I think that speaks to the potential use of propranolol. Next slide, please. And just a warning, if you have a spider phobia, just close your eyes for the next slide. Next slide. This is the tarantula, approach task, the end result. Next slide, please. And then the Merrill Kent, who did the experiment with the tarantula, then extended this into PTSD. And she has a very small case series, just a few cases, where she deliberately identified patients with very serious, life-threatening single episode traumas, and she did an exposure paired with propranolol, and found that it was effective in I think 3 or 4 of the cases. And then there was one case that had a more complex trauma where it was not effective in. This was the example of one of the patients she did this with. And so this is something we use propranolol off-label quite a bit. We use a lot of blood pressure medication like prazosin and clonidine and propranolol and so we can, the idea of using off-label medications in some way like this is I think reasonable, and it would be the idea of having the person doing an exposure therapy and then seeing if the use of propranolol might help to reconsolidate that memory differently by blocking the memory when it was active. Next slide, please. And so, in summary, the field is chugging along incrementally, but earth-shattering practice changes in the immediate future are unlikely. And I think the latest clinical practice guideline sets the field back a bit. We actually recommended in our JAMA Psychiatry critique that we continue for the time being to use the 2017 guideline until we figure out what we're going to do, how to really look at the literature correctly. But honestly, I don't think that recommendation will be followed. I think the VA and DoD are fairly, a large, complex organization that are pretty fixed in its approach to things at times. And so, whether this is, again, my own personal views. This is not official position. This is the personal views of one member of DoD, but not not an official position that I have here. We have to acknowledge and respect the chronicity and comorbidities that are associated with PTSD. And so there needs to be a lot of care coordination. There needs to be a focus on engagement in care. There are a wide range of options that we have available to us, focusing on that engagement piece. And I think the most important thing with trauma-focused therapy is just simply having a real clear understanding of the core components and how we're applying those core components. And as long as you can make a good rationale for how you're applying those core components, I think flexibility in trauma approach is going to be better than more rigid approaches to specific trauma packages. But that's, again, only my own personal opinion. And then I think memory therapeutics through reconsolidation of paradigms might be promising novel approaches, and certainly something that I'm exploring and would be happy to talk further about. So next, I think I have one more slide, which does show my correct email address on it, and a wonderful photo by Tim Hetherington, who unfortunately died while covering wartime activities in the Middle East. He's an amazing photographer. Was an amazing photographer. We don't have a PTSD patch in the U.S. Army, so this was not an authorized patch that this soldier was wearing, but it's quite humorous. All right, thanks very much for your attention, and I'm happy to take questions. We can turn the slides off, perhaps. Yeah, great. And I don't know if someone will look at should I look at the chat? Maybe it would be best if somebody else. Yeah, well, I can't read most of what's in the chat anyway. So anyway, I hope that was interesting, and I'm very happy to take questions and talk further about these things.
Charles, I have a question. We were talking once about acute stress reactions, and when military members are close to front line. So, for example, they have few days, sometimes weeks, and they need to come back to the duty. Yeah, and how deep can be the therapy or psychological care in this case? Because I know my Ukrainian colleagues, they have, let's say, idea that you cannot provide therapy, and one colleague, she even told that, oh, I will hit all hands of the psychologists who will try to make therapy for the soldiers. So what is your experience, and what do you think about making any kind of trauma therapy or more deep work with soldiers on the battlefield and in between the shifts? Thanks.
Yeah, so that's a very individual thing, but I think there is a role for potentially doing targeted therapeutic interventions for specific concerns or problems, even in that far forward environment. I want to say two things about the far forward. The most important thing with the far forward environment, and I know you all have had a number of other lectures about the combat operational stress control practices, but the one thing that I think we've consistently learned over the years is that soldiers will break down in combat. Everybody has a breaking point. It can come from physical and emotional exhaustion, sleep deprivation, the physical wear and tear on the body, the traumas that they're exposed to, et cetera. And so when people have serious acute stress reactions or combat operational stress reactions that cause them to not be able to function in that environment, the most important thing is to provide the care that they need in that environment and as far forward as possible, and only pull that back when that process has gone on for too long a time that you don't think it person has an opportunity for recovering in the far forward environment. But what we've learned is that if you just provide reassurance, grounding, normalization, basic affect regulation, sleep, management, and you provide that for a short period of time, 2 or 3 days, in that as close to their unit as possible, keeping them connected to their unit, that's the most effective thing for those types of reactions. And then, of course, there's wonderful trainings like iCover, which is even for the more acute, soldier breaking down in the midst of a firefight, for instance. What can the battle buddy do to help them get through that, right? So that's what we've learned in terms of treating in the far forward environment. Now, in terms of in that environment, can you also provide targeted trauma-focused treatment? I think you can. Okay, I think there are situations where a person, for example, and we've done. There have been clinicians in the operational environment in Iraq and Afghanistan who have utilized these tools, EMDR techniques, for instance, or other techniques in the combat environment. And I think that as long as you're really clear on what the target of treatment is, you obviously can't you can't do a full course of trauma-focused therapy in that environment. That's not going to be possible. But if, for instance, the person is having a severe grief reaction from the death of a close team member, that you might be able to do a targeted focused treatment, grief intervention with 1 or 2 sessions that could be very therapeutic for that individual and help them to get back in the fight. And involving those core components that we talked about. So it really depends on the situation. I agree that you can't get into, full-fledged, deep, trauma-focused therapy work, but you can do very targeted treatment using trauma-focused techniques in that environment, I believe.
Thanks a lot for a very comprehensive answer.
My pleasure. Thanks for your question.
Антоне, там в чаті питання від Тетяни Хрещук. Можна його перекласти? Чарльз, будь ласка, подивіться там англійською мовою питання. Чи у вас є досвід з терапією травами і терапевтичними садами?
Gardens as in planting? Okay, so therapeutic gardens, we actually have there are some environments, some therapeutic environments that have been created in some of our military bases back in the U.S. So I think that yes, and those types of things can be helpful. And in terms of herbal remedies or interventions as a whole, so I'm just going to use this kind of as a little bit of a springboard for talking about complementary and alternative and integrative approaches, medical approaches, because a lot of patients do benefit from all sorts of non-traditional therapeutic interventions that are not evidence-based, that don't have the evidence to support. There's a lot of herbal remedies that are used that don't have the evidence base to support their use for the treatment purposes that they're being used for. Some of them also have harmful effects, so you have to look at that. But as a whole, there are benefits to a lot of complementary and integrative approaches. In number one, and when patients share that information with us, being able to work with them and help them to feel comfortable with what they're doing can help them to stay engaged in care. And then some of those approaches can be very effective for individual symptoms. So for instance, mindfulness, meditation, yoga, other types of physical exercise or physical practices that individual can do, Tai Chi, for instance, which I do. Those sorts of things can be very helpful in helping the person get better rest or better physical conditioning or better sleep or reduction in chronic pain, those kinds of things. And so having those complementary approaches integrated in with the rest of medicine is something that I think that we've struggled with over the years, and there's been some growing pains. But as a whole now, we're doing a lot better with that. And I think there's a lot more acceptance that these type acupuncture, for instance, for chronic pain, that even though there may not be a strong evidence base, they can still be valuable to patients, and we can incorporate those processes into our medical care. I don't know if that directly answered your question, but
Charles, how much of the alternative in complementary medicine do you think might be a placebo effect? And are there ways that as a discipline we can exploit and maximize these powerful placebo effects that you referred to earlier?
I think that, well, okay, so the placebo effect, I think a lot of people view the placebo effect as something that's, that's undesirable, but the placebo effect is actually something that we can leverage. And and there's a lot of components to the placebo effect. So there was a fabulous randomized trial looking at acupuncture versus sham acupuncture for the treatment of irritable bowel syndrome. But they actually, they told individuals they would be randomized into one of those two groups. What they actually did was they put everybody on the sham treatment initially before they randomized them. And they treated for them a while with sham acupuncture, but they provided the sham acupuncture in different ways. One way, basically a technician would come into the room and do the sham acupuncture without much verbal interaction with the patient. And in the other, the individual would come into the room and they would have a conversation and they would ask how the patient was doing and what symptoms there, and they would go through a whole warm, process, healing process, including a certain amount of time, listening